Hey everyone, today I'll be talking about diabetes. So this will include type 1 diabetes mellitus, diabetic ketoacidosis, type 2 diabetes mellitus, hypoglycemia, gestational diabetes, and then I'll also end it with sick day management. So let's start off with type 1 diabetes mellitus. So it's an autoimmune disorder, so which means the pancreas no longer makes insulin. Usually occurs in about less than 30 years of age, and usually the patient presents with the three P's, which is polyuria, polydipsia, and polyphagia, which basically sums to patient is peeing a lot, patient is drinking a lot, and patient is eating a lot or has a lot of hunger. So they're very thirsty, they're very hungry, and they keep peeing. So diabetic ketoacidosis is a kind of a life-threatening complication that occurs from type 1 diabetes mellitus, and you can kind of think of this as like extreme hyperglycemia. And other complications that can occur is you can get poor wound healing. So that's why you'll often see like if you work in a pharmacy, we'll usually do follow-ups on diabetic foot infections, retinopathy, yeast and UTI infections, neuropathy, nephropathy, and also increased CV risks. So usually you want the patient to do at least a foot exam at least once a year, and you usually want them to check their feet at least daily to see if there's any foot complications. Another thing to note with diabetic foot infections is something that's interesting is when you counsel them to cut the nails, you want them to counsel them to cut straight across and not to cut like the sideways to get the whole nail off, and that's just because it increases the risk of ingrown nails. And then you want to do eye exams about 1 to 2 years. One eye exam at least every 1 to 2 years. So diagnosis is a fasting plasma glucose of greater than 7, but that's a no caloric intake for about 8 hours. And then you want a random plasma glucose when you do a 75 gram glucose test. Should be about 11.1, and then also HbA1c, which is greater than 6.5% for non-pregnant patients. And then treatment will usually be insulin, and then you want to titrate that to the levels that you want. Usually about 7, less than 7, and then less than 10 um, after a meal. A typical regimen is usually a bolus insulin (TID), so that could be like your rapid acting, intermediate acting, or your short acting, and then your bedtime basal dose, which can be either just the long acting insulin, or you can have the intermediate, which is dosed at twice a day. Typical target levels are HbA1c, preprandial 4 to 7, postprandial 5 to 10, and that should be percentage for HbA1c. And usually the way I remember it is 4 to 8 is great. So this typically usually is a normal range for BGL levels. Um, not exact, not not too exact, but it's just supposed to give you a rough idea to look at some information quickly and process it on an exam. So there's two phenomena we're going to deal with. So one is this, I'm probably going to pronounce this wrong, but it's the Samogi phenomenon. Basically, I remember as so much insulin, and you're going to lead to morning hyperglycemia. So what happens is basically you get nocturnal hypoglycemia followed by that rebound hyperglycemia, and this is just because you've got a surge of hormones trying to compensate that insulin resistance, and that's why you'll have high BGLs in the morning. So the way to treat it is you either lower your nighttime insulin or have a snack before bedtime. And then you got the dawn phenomenon, which is down insulin, which leads to morning hyperglycemia. And so that's like your overnight blood sugar is normal, but increases in morning hours around 2 to 8 a.m. Basically, this overnight surge, again, it's caused by that surge of hormones. So it could be like your cortisol, like your stress hormones, and that leads to the morning hyperglycemia. And the way to treat with this is to either increase your basal and insulin dose. My God. Either increase your basal insulin dose, or usually this is your nighttime insulin, or have an early dinner, or do light exercise after dinner. So I guess the next question is, okay, well, we know what to do, but like, how do we distinguish it? And the best way to do it is probably to check your BGL levels around 2 to 3 a.m. So remember that Samogi is like a rebound hyperglycemia. So this is the key word, rebound hyperglycemia. So initially you're going to start off with hypoglycemia, and then the dawn phenomenon is your blood sugar is normal, but then it increases to hyperglycemia, right? So basically, at 2 to 3 a.m., if you notice hypoglycemia, so that would probably be like um, a level like around less than 4, so about like 3 or 2, that will be a Smoji effect. So that's going to tell you to treat it with that nighttime insulin dose or have a snack before bedtime. If it's hyperglycemia, then it's going to be the dawn effect. So that's something like a reading, um, probably like a reading, I would say probably maybe at least around 8, 9, because that's your fasting levels. So by 8, 9, 10, 11, that would be it. Now, if you get a reading, actually, if you get a reading of about, I forgot the number now, 13.8, that would be diabetic ketoacidosis. So I'm just going to get into that. So it's most common in type 1 diabetes because, again, there is no working insulin to offset it, right? So you'll more likely see this in a type 1 diabetic medication. It's basically extreme hyperglycemia. And some etiologies is it can occur from infection, something like iterogenic, such as corticosteroids. Common one is like prednisone, infarction, like an MI, or ignorance, which is basically the patient being non-compliant with their meds. And also infant on board, which can lead to gestational diabetes. So remember, it's an increase of your BGLs. And so the patient will present with nausea, vomiting, diarrhea, headache, and then you got the polyuria and the polydipsia, and that's because the body is just trying to get rid of those toxins. So you'll see the patient present with like a fruity acetone breath, deep breathing, and then dehydration, which also contribute more to that deep breathing because of the tachypnea and the tachycardia. And just to note that dehydration may also mask the respiratory infection as well if it is present. So that's kind of how it relates to something like pneumonia. It would be like a respiratory infection. Diagnosis. So basically, like I said, BGLs greater than 13.8. Oh, sweet, I remembered it right. And then, or it can also be 250 milligrams per deciliter. So it's just the units here. Millimoles per liter is pretty much the regular ones you think of, like when you're measuring blood glucose levels. It can also present with metabolic acidosis with a high anion gap, so that would be pH less than 7.3, and sodium bicarbonate levels of less than 22. And then obviously the main one, why it's called ketoacidosis, is the positive ketone bodies in the urine. And just to note that keto sticks detect acetoacetate. Okay, so treatment for this is like sips of water, so basically saline. And once your BGLs are stabilized less than the 250, you want to switch over to the dextrose 5% because of the insulin, right? So you got the insulin, need some way to uptake that glucose. And there's potassium, and as well you want to search for that underlying cause, which is the last S. So just a note about potassium. There's actually two notes. So do not use potassium supplementation if it's greater than 5.3. So the normal range is about 3.5 to 5.1. If you give potassium supplementation greater than 5.3, it increases that risk of hyperkalemia. Now another point to mention is the insulin as well. So insulin is able to push the potassium back into cells. So if it's able to push it back into cells, this can result in lowering of your potassium levels. So you want to be cautious when your level is about 3.3 because this can cause hypokalemia. And then you can also use sodium bicarbonate if your pH is less than 7 as well. Oh, I wrote that note twice. Okay. So type 2 diabetes. So this is not an autoimmune disorder. This is insulin resistance combined with impaired insulin secretion. So the biggest risk factor for this is going to be obesity, as well as genetics and environment. So again, same presentations, polyuria, polydipsia, polyphagia. So patient is thirsty, patient pees a lot, and patient is hungry. Diabetic ketoacidosis. This can also occur, which is life-threatening as well. Not as much, but it's more likely to occur with type 1. And some other complications Same with type 1, you get that poor wound healing, retinopathy, etc. So you want to bring down HbA1c if less than 8.5% with lifestyle. These targets can vary from patient to patient depending on their symptoms. For example, if someone's dementia. But basically, if the goals are not reached within 2 to 3 months, then we want to do medication, and usually we start off with monotherapy, usually metformin. If if it's greater than 1.5% off target, then we usually start off with combination therapy. So that could be like something, probably a popular one is like a metformin and SGLT2. And then obviously if it's uncontrolled, we can add on either, your other type 2 diabetes medication, whether it could be from just the monotherapy or the combination therapy. Okay, so general monitoring, usually recommend to test your BGL levels about 3 times a day. So that's kind of like with each meal as well. And that's usually if you're on the basal bolus regimen of insulin. You want to obtain a BP target of at least 130 to 80, less than 130 to 80 for diabetics. You also want to check for renal function, which is the serum creatinine and albumin levels. Foot exam annually, eye exams every 1 to 2 years, because the retinopathy and foot infections. And then HbA1c, it takes a while for it to adjust, so that's why they usually check it every 3 months. It's not something you check every month. And then once it's stabilized, then you're going to check every 6 months. And so I just put some of the levels here. So normal individuals, their target is usually less than 7%. But again, you can have certain individuals like dementia, which their target is 8.5%. So an off target for them would be something like 10%, for example. But the reason with dementia their target levels are so high is because well, just because it's dementia, right? So they may forget to take their meds and everything. So they have other kind of factors that may affect it, as well as limited life expectancy. And then if you also have diabetic complications, so that's like your neuropathy or retinopathy, you usually want to aim for about 6.5 if you want to reduce those complications. So typically you'll see probably the 6.5% target for basically younger patients, and then older patients is usually around 7%. And then you want to immunization with pneumonia at year 0 and year 5 as well. And that's just to kind of reduce the complication of diabetic ketoacidosis, which may occur with pneumonia in diabetic patients. And then these are just some of the target levels again. I've already gone over that. So 4 to 8 is great, typical normal range of blood glucose levels. Now, if microvascular complications are present, so this is your neuropathy and retinopathy, you usually want to give statins and aim for an LDL of less than 2. However, if the patient is 40 or older, usually you start their statins regardless, just for the cardioprotection. And then obviously if they have one CV event, they should be given aspirin or clopidogrel as primary prevention. So that's one CV event and plus the diabetes. All right. So let's talk about what happens if maybe we overshot it and the patient becomes hypoglycemia, or maybe they just haven't taken a meal for anything. So those kind of present with the sweating, tremors, tachycardia, hunger, nausea, and general weakness. And severe can be like confusion, disorientation, and then obviously the coma and seizure is probably the worst one. So just a side note, beta blockers can mask these symptoms except the sweating and the confusion. So that's just one note when you're counseling a patient that's taking a beta blocker. So treatment is the 15 for 15. So that's going to be 15 grams of glucose. So that's about 3 packets of sugar. You can mix that with water and 6 lifesavers. And I think there's other options too. I just can't think of them off the top of my head. But as long as it equates to 15 grams of glucose, you can give that. And then you want to test the sugar every 15 minutes. And then once they're about stable, patients should probably consume a complex carbohydrate meal as well, probably within 1 to 2 hours. If patient's unconscious, then you'll have to give the glucagon, which is going to be obviously IM and subcutaneous because they're unconscious and they wouldn't be able to take it PO. All right, gestational diabetes. So this is basically defined as any female with an onset of diabetes or glucose intolerance during pregnancy. It often occurs during the first few weeks of pregnancy, and then it's just kind of to note that it may develop into type 2 diabetes after pregnancy. So this is reason we want to treat this is because you can get complications like miscarriage, cesarean delivery, or malformations. And you want to target about a HbA1c of less than 7%. So pre-pregnancy, you want to begin about folic acid 5 milligrams daily for at least 3 months prior to conception. Then after 3 months gestation, you want to reduce it down to zero point 0.4 to 1 milligram daily, and then continue 6 months postpartum or after birth. And then for the actual diabetes itself, you want to usually give rapid acting insulin. Um, and then another alternative is you can give metformin as an alternative. Um, the other medications, you may see patients sometimes on them. There's not too much research or solid studies to back up. I remember even seeing a patient that was taking semaglutide or Ozempic as well. But just for now, just for the exam, just kind of remember that it's usually insulin, rapid acting insulin, or metformin. And if they gave birth and the breastfeeding, usually metformin or glyburide can be given as treatment and safe in breastfeeding. Okay, let's go over sick day management. So sick, which is basically if they're sick, you want to measure the sugar every 3 to 4 hours and at bedtime. Insulin, you're only going to take the basal dose. So the basal dose is the long-acting insulin, just that one, and you're going to stop the bolus dose unless their BGLs are kind of elevated that you need to give it in order to reduce the risk of diabetes ketoacidosis. And then you also want to maintain your carbs and nutrition and fluids. Try to limit caffeine just because of that diuretic effect. And then ketones, again, you want to watch out for that diabetic ketoacidosis. So that's why you want to check it every 3 to 4 hours and at bedtime. Okay, now if dehydration is present, there's certain meds you may want to stop because it worsens renal function. And so I gave you this acronym to help remember it, but I'm also going to provide you a description because obviously in pharmacy there's way too much to learn, and if you kind of understand the underlying reason, it'll kind of help it better. So sulfonylureas, if you watch my other video, I kind of go over that sulfonylureas are kind of one of the only diabetes medications, um, which can cause hypoglycemia as monotherapy, where the other ones kind of require like a combination therapy in order to result in hypoglycemia. ACE inhibitors, they cause that efferent arterial constriction. So if you know about the triple whammy, so it causes that decreased renal perfusion, uh, triple whammy, decreased renal perfusion. Diuretics cause that hypovolemia. So if you're excreting out all those electrolytes, you're going to get electrolyte disturbances. So something like hypochloremia, hypomagnesia, hypocalcemia. Um, so that would be something like furosemide. Just to note that something like thiazide diuretics, they don't cause hypocalcemia, hypocalcemia. They do cause hypocalcemia, but hypocalcemia is not seen in thiazide diuretics. Metformin causes that lactic acid buildup as well. And then you got your ARBs, same thing as the ACEs, efferent arterial constriction, which increases that renal perfusion. NSAIDs have two ways of damaging the kidneys, which is that they cause the afferent, not efferent arterial constriction, resulting in decreased renal perfusion, and then also inflammation of the glomerulus, which leads to nephritis. And then SGLT2s, because the way they work on peeing the sugar out of your urine. They can also cause a little bit of hypovolemia as well, which can also lead to that electrolyte disturbance as well. And just some other notes, so some drugs which cause dysglycemia, so usually your SGAs, second generation antipsychotics. So some big ones would probably be your olanzapine and your clozapine. It's not seen too much with first generation antipsychotics. First generation antipsychotics tend to have more EPS effects, extrapyramidal side effects, compared to second generations, where second generations don't have as much EPS effects, but they have more metabolic abnormalities. Beta blockers, but they don't increase the risk of hypoglycemia. It's just they sort of mask the effects as well. And then you also got the hydrochlorothiazides as well. And important to note that loop diuretics can also contribute to the dysglycemia as well. And then this one I kind of included in there because corticosteroids is kind of like it just causes a lot of adverse effects, and one of them is the increased BGL levels by decreasing insulin sensitivity, which increases the insulin resistance. So I think it's really important to kind of know this. So this occurs by increasing the glucose production in the liver and the adipose and muscle tissue, and that results in that decreased glucose uptake. So if you take it in the morning, it will rise and stay high till early evening, then decline overnight. So that's one of the things you'll see with corticosteroid therapies. And one thing you should counsel on diabetic patients that they'll see they're higher than normal blood glucose levels, and just make sure to discuss with the doctor like what kind of targets they should be aiming for. Because remember, once you hit that 13.8, you're in that diabetic ketoacidosis territory as well. All right, so that kind of sums up the diabetes lecture, and I kind of hope that helps with your studies. Good luck on your exams.